Hello everyone, my name is Jen Nolan and I'd like to welcome you to our webinar this evening. We are very grateful to Peninsula Hot Springs for sponsoring this webinar. Peninsula Hot Springs is an award-winning natural hot springs and day spa destination on the Mornington Peninsula, just 90 minutes from Melbourne. We will also be having a stretch break during the webinar in compliments of Peninsula Hot Springs. In line with Musculoskeletal Australia's focus on empowering consumers through education and support services, we have been offering a series of webinars for a consumer audience during 2019. Our list of webinars should be on your screens now. Now, I know some of you may be watching a webinar for the first time, so if you have any problems during the webinar, please phone the number at the bottom of your screen. As a backup, everyone will receive a recording of the webinar presentation next week, so if any problem can't be resolved this evening, you'll be able to view the recording then. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, if you are listening via the phone, you may not be able to hear the audio during the exercise break video, but it will be available on the webinar recording when you receive it. Our presenter will answer questions at the end of her presentation, but you can type questions for her at any time. The Ask a Question button is the dark blue hand icon in the top right-hand corner of your screen. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Standard Time. Questions will only be answered during the webinar, so again, this is a reason not to leave your questions to the last minute. I'd also be very grateful if all participants could provide feedback on tonight's webinar. To submit feedback, click the yellow icon in the top right-hand corner of your screen. Our topic for this evening is managing and understanding low back pain. Our presenter for this evening is Associate Professor Manuela Ferreira. Manuela is Principal Research Fellow and an NHMRC Fellow at the Institute of Bone and Joint Research, Colling Institute, and Associate Professor at Sydney Medical School, the University of Sydney. She holds the Sydney University SAW Fellowship and is an Oxford Martin School Visiting Fellow from Oxford University. She leads the Clinical Back Pain Research Theme at the Colling Institute, where she oversees a research team on mechanisms, prognosis and management of back pain. She has attracted more than $10.5 million in research funding and leads the first placebo randomized controlled trial of spinal surgery, an NHMRC-funded study that will establish the efficacy of decompressive surgery for lumbar spinal stenosis. We are extremely grateful to Manuela for presenting this evening's webinar, and without further ado, I'll hand proceedings over to her. Thanks very much, Manuela.
Thank you very much, Jen, and it's a great pleasure to be presenting to everyone. I wish I could see your faces, but hopefully you can see mine. All right, so we'll just start. I thought I would just start with this first slide to give you a little bit of an idea where I actually work. So as Jen mentioned, I work at Sydney University. I'm a senior scientist at Sydney University. My background is physiotherapy, so I am a physiotherapist, but I haven't been in clinic for a long, long time. But this is where I work at Sydney University in beautiful Sydney. But I'm actually based at Royal North Shore Hospital. So on the other side of the bridge, where I work with clinicians, patients, and researchers into establishing the efficacy of a number of different treatments for back pain. All right, so let's just maybe start with some of the numbers that we have for back pain. So at this very moment, so approximately 5 minutes past 7, 1/5 of the global population is complaining of back pain. So that's equivalent to 650 million people. So around the world right now, 650 million people actually have back pain. We know that back pain impacts a person's life from their capacity to dress themselves, go out shopping, go for a walk, exercise, as well as their capacity to complete their working tasks. So we know that in Australia, back pain is the #1 cause or the number one reason for people to leave work. And when you consider all of those aspects of the impact of back pain, the estimates show us that back pain is equivalent to 72 million years living with a disability. In Australia, again, right now, 1 in 4 people are seeking care for back pain. And we do know that approximately 60% of people with back pain will actually get better in 6 to 10 weeks. But the main problem is that for most of those, again, a third of those, will actually have another episode of back pain within 12 months. And that adds significantly to the burden of back pain. So this is a very busy slide. It's a very busy graph. But this is from the World Health Organization Global Burden of Disease study published not long ago. This is actually the one published last year. And that just shows a rank. So it just ranks the many diseases in terms of how much impact they have on people's lives. And you can see that around the world, and it doesn't matter where you look at, if you look at low to mid-income countries, high-income countries, but back pain is actually the number one cause of disability all over the world. Now, when you talk about back pain, most people actually think that it's a condition that affects the younger adult or the working age adult. And older people are actually not as often affected by back pain as the younger adult. But this is a myth that is actually not true. So not long ago, a review of all studies published looking at the prevalence of back pain across different age groups showed that even though the prevalence of back pain peaks at around 50 to 55 years of age, when you look at severe back pain, that prevalence increases with age. And for older people, what you see is that not only they have back pain, but when they have back pain, it's more severe. It impacts their daily lives even more significantly. And there are actually estimates that 1 in 10 people older than 80 years of age have severe back pain. Now, again, when you look at older people with back pain, not everyone responds to an episode of back pain the same way. So there has been a number of different studies looking at how people behave, or how the pain trajectories or the disability or function trajectories differ in older people. So what you could actually see is that older people, I should say older women, with lower educational levels, who smoke, who have more comorbidities, and that is, for example, who have multi-site pain, who have cardiovascular disease, diabetes, which is very common, and have had symptoms for longer, they actually are more likely to belong to this group of people who have very high levels of pain that doesn't really improve over time. So these factors are actually determining a bad prognosis. Now, why do people develop back pain? So this is probably one of the most important questions that we should ask. So who develops back pain? Why do people develop back pain? So again, we decided to look at the literature, and we've reviewed over 100 studies looking at all risk factors for low back pain and sciatica. And we found some very interesting findings. So what we found was that people who are older than 44 years of age are actually 3 times more likely to developing back pain than those who are younger. We also found that people who stand, and for example, that's probably required at work, but people who stand for 2 or more hours non-stop without a break, they're also 3 times more likely of developing back pain. The same thing happens if you have to take long drives. Again, whether this is required at work or not, but if you drive for more than 2 hours, your chances of developing back pain are actually 5 times greater. Those professions or those occupations that do require whole body vibration are also more highly associated with back pain. And lastly, being in bed or sleeping, having poor sleeping habits will also increase your chance of developing back pain. Now, while some of these factors are actually modifiable, we are still not very good at identifying the best preventative strategy for back pain. So this is something that we are working very hard on. Now, these are risk factors for back pain. What actually causes back pain? That's an even harder question to answer. So we know that back pain is a complex condition. We know that there are many contributors to pain and disability. If you look at the spine, there are many sources of pain in the spine. So the bones, the ligaments, the discs, the muscles. So there are many sources of pain in the back. And in 8 out of 10 cases, it's impossible to identify exactly what structure is causing pain. We also know that what causes disability associated with back pain is, again, even more complex. We know, for example, that smoking, that obesity, and that physical inactivity, they are highly associated with disability that is caused by back pain. In other words, smoking, obesity, and physical inactivity will actually predispose a person with pain into developing disability. We know, for example, that people with chronic back pain, and this comes from Australian data, so people with chronic back pain compared to people without chronic back pain are more likely to be daily smokers. 38% of people with chronic back pain are physically inactive. This is a very high rate. And 33% are obese. Again, this is a very high rate and much higher than the general population. And we know that it doesn't have to be that way. Okay, so how do we respond to back pain? We've painted the picture. It's not a very pretty picture. It's a lot of pain involved in the condition, a lot of disability. We still don't know quite well what causes back pain, and we know a few factors that will make you more likely of developing back pain, but we're still trying to find the best prevention strategies for back pain. So how are we actually responding to back pain? Well, it's to no surprise that when you think of back pain, the first thing that comes to mind is the use of painkillers. So how do you respond to back pain through painkillers? So what we did was we looked at all the literature published in back pain and all the literature published around the efficacy of paracetamol, the efficacy of anti-inflammatories, and as well as the stronger painkillers such as opioids. So we looked at everything that was published, and we looked at those studies comparing these drugs to placebo, because we really wanted to know if these drugs were more effective than placebo. What we found was a very consistent answer from all of those studies and all of those drugs, that some of these drugs will offer some benefit, but it's a very small benefit. And when you take into consideration the side effects that they actually cause, so for example, we know that anti-inflammatories are associated with high risk of cardiovascular disease. We know the opioids are associated with high risk of addiction. In older people, it's more associated with falls and fractures. So if you take into consideration all of those side effects, the benefits are just not big enough. And again, this was very consistent across all of those painkillers. Unfortunately, again, going back to the older person with back pain, we do know that older person are more likely of getting a prescription for back pain, especially an opioid prescription, than an exercise prescription. Now, the other approach that is very much popular for the treatment of back pain is surgery. So we know, for example, and we've done a study looking at that in Australia, the more complex surgical procedures called fusion, the rate of that surgical procedure has actually increased 300% over the last 10 years. So more and more people are having surgery for back pain. The simpler surgical procedure called decompression, surgical decompression or laminectomy, has also increased over the years. So you might think, okay, it's increasing because it is helping more people. So we tried to look at that to see if it was actually improving and helping more people. So this is just one example of what we call laminectomies or surgical decompression. So surgical decompression is often conducted or offered to patients with spinal stenosis. Spinal stenosis is when you have degeneration of the structures around the spine, and that space in the middle, so this is the normal spine, and this is neurotissue. So that space in the middle, with all the degeneration around the spine, will actually increase. That's called stenosis. And when that space decreases, what happens is that that neurotissue in the middle gets compressed, and the patients have pain, and the patients have motor deficit. They lose power in their legs. So often what surgeons do is that they'll remove this part of the bone, of the spine, to increase that space. So this is what's called laminectomy. So we actually looked at how patients responded to laminectomy over time in terms of pain and disability. So we included over 3,000 patients, and we looked at that response over 5 years. And what you can see here is that patients will actually have a drop in their pain and disability in the first maybe 3 months, but most people will not recover. So for most people, the symptoms will not go away, even though you have decompressed or relieved the pressure over the neurotissue. So that made us think, does surgery actually work for those patients? At the moment, we are conducting the first placebo trial of surgery for back pain. That's called Success. So Success is a government-funded trial, and we are actually comparing laminectomy to placebo surgery to see if laminectomy or surgery actually helps people with back pain. So this is that one specific type of surgery. But what about other types of surgery or other types of invasive treatments? So this is a table just showing very briefly what the clinical guidelines, and clinical guidelines are based on scientific evidence. So what the clinical guidelines actually recommend for acute and for chronic back pain. So when you look at epidural injections for back pain, they're very popular. But if you look at the evidence, they're actually not recommended for acute back pain because there is evidence showing that it doesn't work. When you look at chronic back pain, there is very little evidence proving that it works. So the recommendation is limited use and with care. When you look at discectomy, which is another very popular surgical procedure, when you remove the disc that is usually herniated of the back, again, there is no evidence showing that those procedures work. Laminectomy, we talked about it. Again, there is no evidence showing that it works. So we've done a number of reviews of the literature, and the literature just does not support the laminectomies. And again, spinal fusion, there is no evidence that it works for acute, and very uncertain that it works for chronic. Okay, so I think this is the moment where we have the exercise break.
We're going to be working on the performance of your entire body whilst improving flexibility and range of motion, whilst also aiding in relaxation and stress. All you will need for this workout is a yoga mat and a positive attitude. Let's get started. And then on the last one, you're going to stay down in that shape. And we're going to add on some nice little calf raises here. Now you should really start to feel the legs waking up. And feel that lactic acid starting to build up in those legs. Good. We're going to go for a few here. And then if you feel confident, some nice little double leg raises here, up and down, really firing up those legs. Glutes are working, legs are awake, and then coming all the way back up. Big exhale, back to center. One more. Once you feel like you've got the hang of that, we're going to keep those legs in tabletop, and we're just going to throw on some nice little toe taps here. Now you should really feel that lower abdominals warming up, waking up. Exhaling on the exertion, and then switch to some heel taps. Just floating those legs down with control, bringing them back to the center. Exhale. Inhale to center. Exhale to stretch. Inhale to center. Really waking up the back of the body. Getting all the muscles of the back working. Strong shoulders. Tush squeezed. Length through our leg. Back to center. And then you're going to hold in this shape. Once you've done your last one, coming down onto your elbows, so folding down in front of you, all your weight through your elbows and your forearms, and we're going to take your right leg back behind you. Again, we're not going for too much height, keeping it in long, nice line with your body, and we want to think about flexing and stretching that leg, flexing and stretching the leg, tapping the toe. Bring the leg back up, flex and stretch, just a nice tendon stretch and calf stretch all the way through the back of the body. We're just firing up those glutes. Flex and stretch the foot. Back to center.
Okay, so I believe we are back. Just before I go on, there was a very interesting question about posture. So is that true that maintaining a posture for too long is more likely to lead to back pain? And yes, it is true that if you sustain a posture, whether it's sitting, whether it's standing, bent over, or even extended, the upright posture, very rigid military type of posture. So if you sustain a posture, that's bad for your back. Yes, it is. And there is evidence showing that. So you have to think of your back as a number of joints that need to move. And any sustained, again, posture or position will actually increase your chances of having back pain. So great question. So, okay, let's go back to treatment then. So we talked about drugs a little bit. We talked about surgery a little bit. Another question that is often asked by both clinicians and patients is about x-rays. So do I need imaging? I don't know what's going on with my back. I want to know, I want to look inside, and I want to know exactly what's causing my pain. Remember we said that we are still not very good at identifying exactly what is causing back pain. And this is because all of the studies on imaging, they actually show that the symptoms are not well correlated with the findings of x-rays. So sometimes you find, or MRIs. So sometimes you find a disc bulge or you find an osteophyte in some of those types of imaging, but that doesn't necessarily correlate well with symptoms. It's very often you'll find osteophytes and disc bulges in people with no pain at all. So we have to be really careful when we talk about x-rays and imaging. So we do know from past research that contents of imaging will strongly influence the clinicians and the patient's beliefs. So people who have an MRI are more likely to think that there is something serious with their backs and more likely to have unnecessary surgery and to have unnecessary strong painkillers. Abnormal findings, again, are increasingly prevalent in older people and in people with no pain at all. Again, because there is a poor correlation between symptoms and findings. We also know from many studies in the US that early imaging, so people who have an X-ray or an MRI early on in the episode of pain, that is associated with poor prognosis. They tend to have pain for longer. They tend to have more disability for longer. Findings in X-rays and MRIs do not predict who is going to recover, and more importantly, they do not predict who is going to respond better to one treatment or the other. So in other words, there is little or a small role for imaging in the treatment of back pain. It is important, so we're not saying that no one should have an X-ray or an MRI. It is important, especially when your doctor suspects that there is something more serious, like a fracture in your back. But other than that, it's really, there is not much relevance or not much help that imaging can offer. So we've talked about pretty negative things, haven't we? So we've talked about painkillers not working, we don't need imaging, we don't know where it's coming from, surgery doesn't work, but it's not all bad news. We actually know now that very simple measures can help people with back pain. So while we know that injections, drugs, and surgery have a very limited role in the management of back pain, we now know that exercising, keeping active, eating well, and being well educated about your pain, learning how to cope with your pain, that is actually helping a lot of people, and that is actually quite effective. So again, if you look at those tables that we showed before, there is very strong evidence from large studies that when people are told to stay active and when people are educated about back pain, and this is what we are trying to do now, so reinforcing the idea that back pain affects a lot of people, but it's not necessarily associated with a serious pathology or a serious condition. That in most cases, it's a benign condition. It will go away. It will get better within 6 weeks, 6 to 10 weeks. It will get better. And that's for the great majority of people. The amount or the level, intensity of pain that you have is not directly associated with how serious the condition is. This is another very strong myth. So, you know, people who are in a lot of pain, there are more afraid of having something serious going on with their backs. And research has shown that they're not correlated. So it's still safe to move. It is still safe to be active, even though you have back pain. It is safe. It's sometimes pain prevents us from doing, you're not going to run a marathon, so pain prevents us from being active. So we need to modify the activities that we are engaged with, but it's still safe to move when you have back pain. And for that reason, advice to stay active and education are currently all over the world the first line care for back pain, both acute and chronic. Superficial heat, so a hot pack, they can actually help you. They shouldn't be the only approach, the only treatment that you use, but they can actually help you, especially if you have acute back pain. We don't know much about chronic. Exercise. So exercise therapy in the acute episode. So acute, again, I should have said that acute it's the initial stage of your pain episode. So less than 6 weeks duration. So there is limited use, but it is extremely important for people with chronic back pain. So people with chronic back pain tend to be less active, tend to have more muscle weakness. So exercise for them is extremely important. Spinal manipulation. So what usually is done by chiropractors and osteopaths and physiotherapists. There is a role for that as well. Again, it shouldn't be the core of the treatment, but it is very important. I don't know if you've noticed, but all of the very passive approaches to treatment of back pain, so, massage, manipulation, a hot pack, so all of that has very, very limited benefit, because the important thing is for the patient to be active, to move their backs again, and to go back to their normal activities, get stronger. So again, as we said, massage and acupuncture, they have an important role, but it shouldn't be the core of your treatment. And very interestingly, there was a large study published in the US not long ago showing that mindfulness is actually effective for people with chronic back pain. So when people meditate, when they do mindfulness exercises, they can actually help with the pain, and that could actually help with the disability. So that helps them cope with pain and go back to their normal activities. And the same with yoga. So in summary of that part of the management that we were talking about. So the core or the first line care for back pain should actually be focused on self-management approaches. So educating people on how to cope with pain, how to stay active even though they have pain, how to stay at work. It's extremely important. So self-management approaches that are actually based on physical and psychological therapies and some forms of complementary medicine. The first choice of therapy should be non-pharmacological for the reasons that we have already discussed. And there should be less emphasis on drugs, on imaging, and on invasive treatments. And again, exercise is extremely important for people with chronic back pain. It is safe to move. So just before we wrap up, one of the last things that I wanted to talk about is the messages that we should be sending people out there with back pain, whether they're family members or they have someone in the family with back pain, if you're a clinician, if you are a back pain patient yourself. So for very, very long, all of us have either received or given messages like this. So be careful. Moving will increase your pain. Maintain an upright posture. I do remember patients who couldn't actually bend because they're so afraid of bending. They heard their whole lives that they needed to keep an upright posture, that they were really afraid of bending and having more pain. And this is a myth. This is not true. Your MRI shows you have osteophytes, a disc bulge, and facet joint. You will probably need surgery. As we heard, a lot of people will have osteophytes and disc bulges and have no pain. So that's not a good enough reason on its own for surgery. Do not lift any weights. It will increase the strain on your back. Again, there are ways we can lift weights, and there are ways we shouldn't lift weights. So just telling people don't lift any weights, that's not helpful. Your disc is worn out, you need surgery. That's not helpful either. Leg pain means your nerves are compressed in the back and you need surgery. That's not true. So a lot of people will have pain down the leg, but it doesn't necessarily mean that there is any nerve compression. Don't bend over, your discs will slip. That's not true. And if you haven't improved by now, you definitely need surgery. Again, another myth. So that's what we've been giving people as messages. What should we be giving them then? So there is a global effort to change that message around back pain into that negative type of message into a more positive health message. So emphasizing, again, self-management, healthy lifestyle behavior. So being active, eating well, not smoking, reducing alcohol consumption, sleeping well. There is a huge role. Sleep has a huge role in not only the development of back pain, but the prognosis of back pain. So people who don't sleep well are more likely to have back pain and more likely to have severe back pain. On the other hand, people with back pain are more likely to have sleeping problems. So they are very much correlated, sleep and back pain. And there are a number of tools that we can use to improve sleep, sleep hygiene, approaches, meditation. So there are a number of different approaches that we can use to improve the quality of sleep, and that will definitely help people with back pain. Education and advice are key. So, these webinars, what Musculoskeletal Australia is doing, it's absolutely key, extremely important work. Remain active and staying at work. If there are two things that you get out of the whole webinar today, may those be the two things. So it's very important for people with back pain to remain active and to stay at work. Whether remain active is walking to work, getting off the bus, one stop behind or before your normal bus stop, so you can fit in a few steps more. So remaining active, finding ways that you can cope with pain but still remain active and still stay at work. Modifying your tasks at work but staying at work. It's extremely important, and it's strongly correlated with prognosis of back pain. And again, I think this is what we're trying to do now, addressing the widespread misconceptions about the causes, prognosis, and effectiveness of treatments for back pain. So everything that we've talked about now. We are, this is just out of curiosity, so we are actually trying to send that message literally through text messages in collaboration with Musculoskeletal Australia. So we are trying to see if a text message-based intervention that will send this type of message that we're talking about, the positive message, the education, being active, better use of care. So whether sending those messages via SMS actually helps people with back pain. So stay tuned. We might have some more information for you soon. So this is my contact detail. This is my email. If you have any questions later on, please feel free to contact me. And I really want to thank you for listening. And if you have any questions now, I'm open to answering the ones that I can. Thank you very much.
Thanks very much, Manuela. That was such a comprehensive presentation on such an important topic. So we have got a couple of questions that have been already put forward. So if we can work our way through those questions, you answered an earlier question on posture, and there was a question following up to that about how often should a person change prolonged posture.
Okay, so there isn't a magic number. We would say at least every 15 minutes you should change. So for example, if you are at work and you probably see people standing up, people sitting down, even changing postures in their chair every 15 minutes. Sometimes it's harder because 15 minutes, if you're writing something or if you're attending a conference, for example, that you can't, like me, for example, today I can't stand up and sit down. So it might be a little bit longer. There isn't a magic number. You will probably find the magic number for you. I have an internal clock. I know when it's time for me to get out and go for a walk and come back, or leave my desk and maybe come back. But again, according to science, there still isn't a magic number.
And Manuela, why does a birthmark on the spine cause pain?
It depends on what you mean by birthmark. So sometimes there could be some congenital changes to the structure of the spine that can actually compress the nerves or the muscles or the ligaments, and that could cause pain. Again, it goes back to the same thing that we were talking about before. We don't know exactly what structures are actually responsible for pain because there's so many possible structures in the back that could be causing pain.
And a couple of comments in relation to the fact that many of the things that you've said this evening, as your final point made, was that how do we get this message out there better, because the knowledge of the general population and of many health professionals is not, covering some of the points that you have outlined as being so important this evening.
We are trying very hard, and it takes time. Changing paradigms takes a very, very long time, unfortunately. I think this webinar is a great resource. We could do more of these webinars on back pain, so this is a great resource. I've worked with the NPS, so it's a government funded initiative to actually educate GPs and other health professionals, but especially GPs, and we are sending the same message, exactly the same message. I've presented many times, again, at GP conferences, to pharmacists as well, physiotherapists. I work closely with physiotherapists here at the hospital, and again, the same messages. So I think it's just talking to people about it. There are plans of doing media campaigns that will address or focus not only on the consumer, not only on the patient, but mainly the clinician. So I think, it's small bricks, but all of a sudden we'll have a huge wall, and I'm pretty sure that we'll get there.
Great, thank you. Someone else has asked about they fit the bill with regards to age, obesity, comorbidities, and agree that the importance of exercise is vital. But where can they find an experienced physical therapist? Would there be a specific qualification with physiotherapy or exercise physiology that might, that people should be particularly looking for when they're looking for a practitioner?
So there isn't any specifics. For example, there are many physios who are specialized in musculoskeletal physiotherapy. So that's what you should be looking for. So someone who works in a musculoskeletal physiotherapist. There isn't. Most physios will actually get very similar training across Australia. I don't know if you know, but the physiotherapy training in Australia is the top in the world. So the Australian physios are pretty amazing. I don't know exactly where you live, but maybe Musculoskeletal Australia could actually help you identify people around where you are, people who are experienced physios. But I would say again that most physios are extremely well trained in Australia, so you can trust them.
Yes, certainly the Musculoskeletal Australia helpline would be up to provide information. I also know that many of the professional associations, such as the Australian Physiotherapy Association and Exercise Sports Science Australia, probably also have a guide where you can look up those sort of practitioners in your local area. So that might be another resource. A question, what are your thoughts on the focus on core strengthening exercise?
There is actually very good evidence on core strengthening for people with chronic back pain. So we did a study a while ago comparing general exercises, and by general exercises, I mean walking, just some leg strengthening exercises, arm exercises, so very general, and we compared that to core strengthening. And what we found was actually core strengthening could decrease pain and disability in people with chronic back pain much sooner. So there is good evidence on that type of exercise.
Mm-hmm. And how effective, in relation to the strategies of people keeping active and exercising, how effective have they been found to be, particularly in managing pain in the older population group?
So the older population group, again, we did a study not long ago looking at how many, so looking at the participation of older people in clinical studies of back pain. And I'm very, very sad to report that about 60% of the studies in back pain will actually exclude the older person, which is really unacceptable. So there is very, very limited evidence on how effective those approaches are for the older population. But we do know that exercises, especially the exercises that will focus on balance and strength training, we do know that they are effective in reducing pain, musculoskeletal pain in general, in older people. And they're also extremely important in reducing falls or preventing falls, especially injurious falls, so fractures, etc. So these strategies should be used in the older population the same way.
And Manuela, how relevant is the oversensitization of lower back pain by brain post-injury or trauma? Does the brain seem to overprotect an area by sending pain signals, similar to what Lorimer Moseley advocates?
Yeah, absolutely. And that is actually observed in people with chronic pain. And this is why education and getting people to stay active and helping them maybe modify their activity so they could stay active. This is why that approach is so important, because simple approaches or passive approaches such as painkillers and surgery, they're not going to address that problem. So absolutely, it is very relevant.
And is there a role for rest in managing acute radicular symptoms such as referred leg pain, pins and needles, numbness or weakness?
There is a role for rest. There isn't a role for bed rest. So bed rest is just staying in bed and not exercising or not I shouldn't say exercising, but not going back to your activities. So having short breaks throughout the day, absolutely. And we do know most of what I talked about today is related to what we call non-specific low back pain, or back pain that does not involve the pins and needles, the numbness, etc. But in regards to rest and in regards to bed rest, this is a message across all types of back pain. So bed rest is not good for you. Instead of bed rest, short breaks. And whether it's sitting down, okay, sitting down doesn't help me, but if I lie down for 5 minutes, it's really helpful. Okay, that's good. So do it throughout the day, but don't stay in bed.
And your views on back braces while in pain?
It's exactly the same thing as bed rest. So we know, for example, for vertebral osteoporotic fractures, so for older people who have fractures in their lumbar spine and thoracic spine, back braces are actually quite effective because they can go back into moving. They can walk again. But we should, again, be really careful with anything that is too passive. So if the back braces are going to help you walk more or go back to your work sooner, and if you're not depending on the back braces for everything you do throughout the day, it's fine. But if you're actually wearing the back brace and not going back to your activities, that's not going to help you for too long, because what they are doing is the work of your muscles. And your muscles need to do the work for you, if that makes any sense.
And Manuela, would there be, just following on the sort of from the comment about core strengthening exercises before, is there any particular examples of core exercises that you would suggest?
So there is. It depends on how much pain you have. It depends if you do have pain. So, for example, if you don't have any pain, or if you have recurrent pain but you experience an episode of no pain, core exercises involved in Pilates are extremely effective and helpful. If you are in pain now, the best thing would be to see your physio, and they'll walk you through the exercise, because there is there are grades, or you can actually increase how difficult difficulty of the exercise is to help you more. So if you are in pain, I would suggest you go see your physio. If you don't have pain, exercises like Pilates, for example, are quite helpful.
And actually, someone has just pointed out that, yes, the Australian Physiotherapy Association has a Find a Physio tool on their website that people can then sort of look up a specific musculoskeletal physiotherapist. So,
thank you.
Thanks for that. That's great. And a question about where can we find resources to help us educate patients? Certainly on the Musculoskeletal Australia website. Yeah. There's extensive information sheets, a couple of videos and so on, and also our Musculoskeletal Australia helpline is also a good resource to refer patients and clients to. Any other additional suggestions you might have, Manuela?
So the APA will have some information for you, the website, and there is a website recently launched called My Back Pain. They'll have some information for you as well. So if I'm not wrong, it's mybackpain.org.au. But I would strongly recommend using some of the resources of Musculoskeletal Australia. So they've developed the guidelines, the A to Z guidelines.
Yes, so we've got our my pain managing my pain booklet, which is available on our website, and also via hard copy. So that has certainly had excellent feedback from people with regards to some great self-management strategies to actually assist people in managing their pain.
Yeah.
I think we've reached the end of our questions and we're very close to the end of our time. So, Manuela, I'd thank you very much again for a very informative but very generous presentation tonight. You've really, especially getting through all those questions, that's fabulous. So thank you so much to you. And I'd like to thank everyone who has joined the webinar this evening as well. And just advise you that the next webinar we'll be running will be in October. Thanks again to Peninsula Hot Springs for assisting with the funding of the webinar tonight. And on that note, I will bid you just a reminder about the feedback, which is up on the button up on the top right-hand corner of your screen. So it's always great to get some feedback, just so we can always improve and reflect upon about what we offer. So remember to look at the Musculoskeletal Australia website for the resources, or give us a call on our helpline. All the information is on our website at www.msk.org.au. So thanks again, Manuela, and thanks everyone for joining tonight. I wish you good night.
Thank you, everyone. Bye-bye.